You know, I just learned a lesson. You might as well participate in the crime, because otherwise you let others do it for you. And I've got some revenge to pay now. This is a special session for me, for us as a society. And just a little bit of housekeeping. It goes from 10 to 11, or 10 to 11 o'clock. But there's some new and special awards and citations that we're going to make today, and it's pretty clear we're going to go over the hour. We will start the Shaw Symposium whenever this ends, and it will go an hour. So it will go into the lunch hour. So a little bit of housekeeping, and we'll just blame Ehab for that, I don't know, 15-minute introduction, but thank you so much. Brings us to the first section, which is, in fact, a special citation. I'm going to ask Greg Farwell to come up to the podium. It's a new AHNS program chair, special citation, never been given before, very appropriately. Greg.
Thank you, John, and certainly in the spirit of celebration, for the first time ever, the Executive Council has allowed a program chair citation based on a very unique circumstance. I'm indebted to their decision to allow this personal and much-deserved tribute. On behalf of the President, the Executive Council, my program co-chair, Dr. Nepakitis, the program committee, it is my honor to present the posthumous citation to our friend and colleague, Dr. Eddie Mendez. This is a celebration of a career worth emulating. As a junior faculty at the University of Washington, I had the privilege of being assigned as my first resident mentee this incredibly bright, motivated surgeon scientist, Eddie Mendez. As was the modus operandi for the next 20 years, he taught me much more than I could ever impart upon him. During the course of his residency, he did outstanding research, looking as one of the pioneers in microarray technology at the genetic fingerprints of oral cavity cancers. This culminated in an R01 grant when he was still a resident. He went on to subsequently receive nearly $3.5 million in grants looking at novel diagnostic and therapeutic targets against head and neck cancer. He published over 40 high-impact papers and was a frequent invited speaker on both clinical and research topics. And his dedication to science, discovery, and advancing our field was without comparison. In fact, his last manuscript revision was completed only a few days before his death, describing an incredibly exciting and transformative new approach to treating patients with a Wee1 inhibitor. As a clinician, Eddie was equally gifted. He was one of the very first transoral robotic surgeons, and he contributed mightily to the field in training clinicians and studying this new technique. His papers describing the opportunities, limitations, and the future of this approach provided an essential legitimacy to this field. Because of his scientific background, he walked the scientific walk, and he could interact with his peers in medical oncology and radiation oncology. He commanded their respect due to the rigor of his work and the intelligence and the knowledge that he possessed. His patients were the ultimate beneficiaries of his expertise, and many of them were touched to write very sincere and touching notes after his death, expressing their appreciation of his skill and deep commitment during their treatment. Watching his career develop, it was clear that everyone had a profound respect for Eddie. Eddie was committed to diversity, and he served as the co-chair of our society's diversity task force. He was a gifted teacher and recently won the teaching award at the University of Washington. As mentioned, his patients adored him, but it was more. It was his trainees, it was his colleagues, his research colleagues, and most importantly, it was his family. Talking to him over the years, he was quick to describe his wife's latest grant or research paper, his daughter's accomplishments, his family's life in Puerto Rico. Like many of our families, there was a sacrifice that went along with such an accomplished career. He lamented the time away that was required for such an intense career, but he strove to be the best husband and father possible. A few of us had the extreme privilege of spending a couple of hours with Eddie the weekend before he passed, and watching the love between this amazing family was heartwarming, and it clearly demonstrated that Eddie had succeeded in this most important role. As mentioned, Eddie's life and career are worth emulating, and Neil and Margie Futran are spearheading a local effort at the University of Washington to keep his legacy and work in the head and neck cancer alive. In honor of his many contributions to our field, the American Head and Neck Society has graciously named a pilot research grant in Eddie's name to support a young investigator in their formative early years. As mentioned, Eddie was committed to diversity, and he had initiated a campaign to establish a second summer diversity fellowship following Dr. Meyer's generous lead. The goal is to raise $125,000, and this will encourage underrepresented students to get exposure to head and neck surgery. Once funded, the Pilot Research Award naming will transition to the Eduardo Mendez Diversity Summer Traveling Fellowship and perpetuate Eddie's goal to improve our field's diversity. I encourage all of you to participate in helping achieve this objective. Before his death, Eddie was made aware of this citation, and his family have come from far and wide to be here to witness this. They will be available in the Centurion Club for a little while after this, if you're around and would like to say hello. But to his wife, Dr. Ann Manicone, to his amazing daughters, Emma and Julia, to his mother Belkis, his brother George, and brother-in-law, who have come from Puerto Rico and Seattle, I thank you for sharing Eddie with our field. In honor of Eddie's tremendous work, we have awarded him the 2018 American Head and Neck Society Program Chair's Special Citation. And I would ask that you as a family stand and accept the appreciation from our society for all of his contributions.
So thank you so much to the Mendez family again. One of the great honors that the President has is citations and distinguished service awards. There is no greater honor in our society than the Distinguished Service Award, and I'd like to acknowledge Dr. Brian Berkey. Brian is currently the Vice Chairman and Section Head of the Section of Head and Neck Surgery and Oncology at the Cleveland Clinic, Head and Neck Cancer Institute. In his capacity as Secretary, though, of the AHNS, a term that ends next year, he has worked tirelessly. He has served the Society on so many committees, and his knowledge of the AHNS and its workings is, quite frankly, profound. With the reorganization of the Society this year, he was very astute on so many issues related to bylaws, and his attention to detail was absolutely amazing. He provides sage and wise advice to all who ask him. He was perfect, and he is perfect, as a common thread between presidents. As Secretary of the Society, quite frankly, is a thankless job, and the Distinguished Service Award to Brian Berkey for his tireless work on behalf of the Society is well deserved. Brian. I should acknowledge his wife, Maureen, who's with him today as well. Maureen, welcome. My presidential citations are intended to recognize individuals who, over the course of my career, have influenced me, and each one of these awards represents an area of my professional life. The first award recognizes my colleagues who I work with at the American Head and Neck Society. The first presidential citation goes to a person who is well-deserving, Jeff Myers. Jeff represents so many AHNS colleagues who I've worked with over so many years. People who become friends, not just acquaintances. And saw one of the examples of that in Hiab's presentation of me. Basically, I have followed Jeff through the program committee and conference chair stream for the international meetings over so many years, 12, maybe 16 years. We have worked together on 3 international meetings, and of course, during the course of our commitment to the executive, Jeff's professional accomplishments are incredibly well known, and all of the bios of the citation winners are in the program. But personally, he is a terrific friend, person, dedicated to doing the right thing. We share a passion for hockey, just different teams. Your team won't win this year. I don't think. Obviously, members of his family are incredibly well known to this society, and I know he spends a long time walking his dog every day. I think that's his common passion as well, drinking beer with his sons too, of course. Jeff Myers. The next citation goes to Dr. Ralph Gilbert. Ralph represents the surgeons who I work with every day. There is no better person to represent our team and to represent high-quality surgery. He is a leader, dedicated to excellence. His standards are incredibly high, and he pushes all around him to do better. He leads by example. He is a creative thinker, an innovator. He's a strategic thinker, and if I have a case I need advice on, I go to Ralph. He's a go-to guy. There's never a doubt, quite frankly, on where Ralph sits on a matter, and it is usually right. Well, okay, if you ask him, it's always right, but that's another thing. This is his new grandchildren with Marianne. Emily and Richard, I think probably at Richard's graduation, and appropriately skipping the boat as a skipper of, first of all, an accomplished sailor, and appropriately always in control. Ralph is the consummate surgeon. He is one that we all strive to emulate, and well-deserving of my personal recommendation as a presidential citation. Ralph Gilbert. Ian Witterick. Ian represents my academic life at the University of Toronto. He's the chair of the Department of Otolaryngology Head and Neck Surgery at the university. Ian and I are basically of the same vintage. He's maybe a year behind me or a couple of years separated, but basically we've grown up together through the department. He has become an outstanding chairman. He is an outstanding leader, and he has really redefined our department in every way. I think Ian's biggest accomplishment is that of a mentor of residents, a mentor of students, a mentor of fellows. He's currently just past president of the North American Skull-Base Society. This is a slide that really demonstrates Ian's mentorship in our department. Truly a chairman. Notice that somehow there's always sailing boats in our department and people at the helm. This is his family, Jenny and Matthew. Ian's ability to manage people is a profound one, and obviously well-deserving of a presidential citation, representing my life as a university professor, Ian Witteright.
Thank you.
Robin McLeod. No one knows Robin here, but man, she's probably affected me more than anyone else. Robin flew here especially for this citation. She's not a head and neck surgeon. We'll forgive her for that. She's an accomplished colorectal surgeon. She's worldwide known. Robin represents the clinical champions and surgeons who make a difference in healthcare policy and implementation in our province. Robin and I started working together, 12 years ago? And essentially, over the course of years, she's an incredible partner. She gives me advice, and she pushes me to do better. Now, let me tell you, Robin and I don't always agree, but we never hold a grudge, and we move forward. And that is really an outstanding quality. And we move on, and quite frankly, we usually do it her way. She's from Spruce Grove, Alberta. This is Spruce Grove, Alberta. Her father had a general store. She went and was educated in a 2-room schoolhouse, I think in a couple of streets down. And Spruce Grove, Alberta is a lot different, I think, today. This is her team that she formed of surgeons at the Mount Sinai Hospital, one of the top colorectal teams in our country. And she is the one who deserves credit for forming that team and many teams around her. This is her home team, her daughters, and her husband, John, on this slide as well. Her current team is Vice President of Clinical Programs and Quality Improvement at Cancer Care Ontario. Is in the capacity that I now know her. She's responsible for really clinical care, surgery, radiation, medicine. I report to her now, and she's responsible for everything we do, and I want to thank her for everything she's done with regards to quality improvement in cancer care, and specifically in cancer surgery. Well deserving of a presidential citation. My next presidential citation couldn't make it. She's 38 weeks pregnant. That would be a long pregnancy. I work with Amber Hunter. She is an outstanding manager of our surgical oncology program. In her capacity, she's improved quality in our cancer system over the course of many years. She is an example of the professionals I work with in health policy implementation. Unfortunately, she couldn't be here today, but this citation I will give her personally. The next citation's a controversial one. Well, you know, this is an unusual circumstance. Quite frankly, my wife. But, you know, she shouldn't be penalized for that. She's a Canada Research Chair in dysphagia. She completed 2 master's degrees and a PhD. She's a leader and really emulates the people we work with, our allied health professionals and those who describe how our patients do. Not just survival curves, but our function. And I think Rosemary really emulates that. Her current research interests are developing models and tools, medical outcomes of dysphagia. She's also a principal investigator in the implementation of a tool called TORBEST, which is worldwide used for stroke and a descriptor of bedside assessment of patients after stroke. It's, I think, been translated into about 8 languages, and it's probably the most common tool used in the world as a bedside assessment of patients after stroke and rehabilitation. Most recently, she has been successful as a co-principal investigator in the PCORI grant, in obtaining a PCORI grant, which is an $8.5 million grant for the study, a multi-center study to look at the benefit of swallowing therapies for patients with head and neck cancer. Obviously, this has been done with a team. This slide demonstrates her mentorship of many students over the course of many years. About 2 years ago, and the last 2 weeks in August is really held sacrosanct at our home as a holiday time. And one day, I remember coming home and saying, I'm looking really forward to the vacation next week. And Rosemary told me, yeah, perfect, we've got some guests coming. And she didn't tell me the guests were basically a grant writing team, many of whom you see on the slide here. Tim McCullough, Kate Hutchinson. And they basically came up to our farm for 4 days and wrote the PCORI grant on our patio of our farm. Well, let me tell you, these individuals, experts, world experts in dysphagia, do not have dysphagia. The wine cellar at the Cello Bello, our farm, has been depleted ever since. But I'm very pleased that they were successful in obtaining this grant, and Rosemary was probably the driving force, one of the driving forces behind getting this. Well-deserving in her own right of getting a presidential citation, Rosemary Martino. I'd like to acknowledge the fantastic work done by our program chairs. Greg Farwell. Greg Farwell has done an amazing job over the course of this year in creating a program that is innovative, unique, engaging, and I think has also set a standard. And I want to thank you, Greg. You're a great friend, you're a great mentor, and a fantastic work as the program chair for the 2018 AHNS meeting. Great.
Thank you.
Danny Anacopides, wonderful. Again, program co-chair. Danny is the chief of surgical oncology at Sunnybrook Odette, also the chief of Department of Otolaryngology, Head and Neck Surgery. These two have been partners in crime and done a wonderful job. Innovative, engaging, and again, setting the new standard for our AHNS meetings. Thanks so much, Danny.
Thank you.
Now for the most anxiety-provoking event that occurs during the course of one's presidency. We're all used to, of course, giving academic talks. We're used to giving keynotes, but addresses, that's something different. And I want to thank you again for the honor of serving as your president this year. Fighting a cold, so we'll see how this goes. I got my fluids here. There's also, during the course of the presentation, one glitch which seems to sort of stop during the presentation, so our technicians back there may have to do some fancy work that'll delay us for about 10 seconds. But I want to thank you for the honor of serving as president this year. When I was asked for the title of my presidential address, one word came to mind, and that was reflections. Now, when you look up the word in the dictionary, it seems appropriate: serious thought or consideration. And that kind of sounds presidential, and I know that's important. And if you look below the definition, reflection is actually used in a sentence. He doesn't get much time for reflection. Not only does that sentence use the word, but it also makes a statement. We don't get enough time to reflect, and I, quite frankly, certainly don't. And when I saw the second definition, I knew I had the right title. The second definition, and those from the physical sciences actually probably even thought of it first, reflection is the change in direction of a wavefront at an interface, at a waypoint. And our society is at that waypoint, at that interface, as we launch our new organizational structure, but also as we look at the challenges and opportunities before us and our specialty. And in that context of reflecting, but also looking forward, that is the foundation of this address. I'm going to paraphrase a great hockey player, of course. A good hockey player plays where the puck is. A great hockey player plays where the puck is going to be. And to paraphrase one of the greatest athletes from Canada, I think it is paramount for not only trying to predict the future, but to help create it. And we have plenty of opportunities to change the future. As surgeons, we have critical roles in healthcare. Our role as a surgeon, one who is committed to excellence in the care of his or her patients. Our role as a member of a healthcare team, a sum that is greater than its parts. Building not centers of excellence, although that is invariably what results, but centers of experience, centers of team experience. Our role as a researcher, our role as a teacher to teach others to take it forth and hopefully do it better than us. And I would like to reflect on each of these challenges that each one of us face, each one of our centers, our society, are facing as we reach this waypoint. As I look back 26 years now to the start of my career, we had two-dimensional films and film viewers and film boxes and film libraries where we picked up images for review of cases. Who would have envisioned that the eyes of the surgeon today would embrace three-dimensional imaging, and in fact, four-dimensional imaging, as we understand the importance of how tumors change over time during the course of surgery or during the course of radiation treatment, and the increased understanding and inherent understanding of tracking, navigation, and the potential for near real-time, on-the-table imaging as we operate. The bringing together of all of these technologies into a single surgical dashboard, incorporating axial, coronal, sagittal imaging with navigation and virtual reality. And to increasingly incorporate auto-segmentation software to delineate targets and no-fly zones. And someday these targets and no-fly zones will actually be painted, potentially, by particles, nanoparticles, and so on. And who would have really predicted that the hands of a surgeon could be a robot-guided hand 26 years ago? Who would have actually predicted that? But looking forward to the future, that the knife of the surgeon could very well be a fiber optic transmitted light that excites a multifunctional nanoparticle with the capacity for fluorescence and therapeutic ablation. The eyes, the hands, the knife of the surgeon will be different tomorrow, just as they are different today from yesterday. And I think we're at a waypoint. in our research. I think, for example, as we enter an era, and just using this as an example, of emerging nanotechnology with molecular and image-guided surgery, or for that matter, any other new innovation, are we ready? Increasingly, we will need to deliver innovation from the lab to the operating room laboratory, where we are no longer just creating and innovating in our wet labs, but translating that to patient care, and of course, because we are researchers, to evaluate and to measure whether we are doing it better, and when we do, to educate those to take it forth. Create, innovate, translate, evaluate, educate. That was true 25 years ago, it is true today, and it will be true yet again tomorrow. But let's just take the emerging nanomedicines as an example. As we start to merge nanotechnology and nanoparticle development and embrace the power of multimodal, multifunctional particles that will not only allow us to see better, the eyes of a surgeon, as we embed fluorophores, iodine for CT imaging, manganese for MRI scan imaging, copper for PET imaging, but not just multimodal molecules, but ones that are multifunctional, diagnostic and therapeutic, theranostic molecules. Multifunctional molecules that can be turned into agents for therapeutic, photodynamic, photoablative molecules with the introduction of targeted laser light. But as we go and start to look at an era of translation and first in human in many of these developing areas, we need to arm our operating rooms, laboratories with assets that allow for translation part of the pathway, that will truly give us the sum that's greater than its parts as we integrate all of these technologies, from surgical planning to preoperative imaging to intraoperative cone beam CT or other imaging, surgical tool tracking, optical imaging into a single common dashboard, as we singly and integrate these into our operating room systems. But as we create these innovations and have a vision for the future of surgery, do we have the same vision for the infrastructure and co-structure needed to support that future vision? Have we created the human resources to innovate and support this vision as we think of the new surgical guidance systems, integrate new imaging modalities, and look at the next era of 3D imaging, tracking, endoscopy, robotics, supported by the respective software and hardware architecture? Have we created the teams and not just the systems? The software, electrical, computer, structural engineers, the physicists, photonic scientists, nanoparticle scientists, not only to create and innovate, but also to support the programs and be integrated into the surgical team. Have we created the physical resources, the physical spaces for the ORs of the future? Not just operating rooms, but operating room laboratories, where we create and innovate, not just in the laboratory, but as surgeons, we translate that to patient care. And have we created the research organizations and research structures that incorporate new technology and discovery as we enter the era of increasing translation of our science, including technological science, into our operating rooms and clinics? Let's maintain the scientific rigor of assessment. The same as new drug discovery should be applied to technology discovery as well. Anything less undermines our integrity. We're also at a waypoint as educators, a reflection point for our society. As the members of AHNS are increasingly challenged by other specialties providing head and neck surgical care, we will need to ensure that we maintain the highest of principles. Rather than saying we should do it, we need to establish the strongest education programs to ensure that we provide the highest standards of care and that we describe what we do and be public about it. The AHNS is well positioned in this regard. Our Education Committee has developed a strong fellowship curriculum. Our TAC Committee, under the leadership of Terry Day, is developing strategies of how to integrate those into accreditation and certification. We need to continue to ensure that our fellowships remain strong, robustly accredited so that the next gen of head and neck surgeons provides the best care for our patients. Ultimately, we cannot be viewed as protectors of turf, but protectors of patients. By developing a clear and concise set of standards that describes how a head and neck cancer patient should be treated, by whom, by what training that person has, where, and how, and we should embrace and describe our outcomes related to how we do it. And as our teachers think of the new innovation, and as our research leaders think of new advances, perhaps this is our greatest challenge. One thing is clear, our systems, whatever side of the border you're on, are expensive and getting costlier. And furthermore, this is accentuated by the fact that the silver hair tsunami of baby boom generation is about to age into the period of their lives that generate the most healthcare expense. And quite frankly, we are part of the problem. We will continue to develop the drug, the new innovation, the new particle radiation treatment, the new robot. We will do our jobs very well. And as we are on a waypoint of implementation of many of these advances, we will increasingly ask, not can we do it, but should we do it? Some choices will be obvious. They will bend the curve like this. They will increase survival by percentage points over 5 and 10 years, but some may increase life by a few months, and will increasingly be faced with tough questions. What is the cost? What is the benefit? But let's be very clear. Some of the barriers to implementing these innovations will not be driven by cost or benefit, but a significant barrier will be us. This is an actual curve of change that could be made everywhere. For every 25 units of this product, there's a 3% improvement in survival in head and neck cancer. Furthermore, it can be implemented at less cost. Which brings us to our last role, that of as a health system leader. The surgeon in his or her role as an expert on the management of patients in a healthcare system, an expert on health policy, healthcare delivery, and healthcare in a system, translating outcomes and health services research into health policy change in a healthcare system. In the same way that we translate our discoveries in our wet lab research to intervention, we need to do the same in health services research. You see, I showed that curve earlier. You've seen that before. I said that for every 25 units of product, there was a 3% improvement in 5 and 10-year survival of our cancer patients. Well, those products are patients. These curves show a 3% improvement in 5 and 10-year survival for every 25 additional cases seen at a center, at an institution. For 100 patients, that's a 10 to 12% improvement in 5 and 10-year survival. And I also said the impediment to some of the innovations will not be driven by cost, but also said that the significant barrier will be us. You see, this survival curve is that associated with regionalization of healthcare services, and specifically head and neck cancer services. And this is where surgeons can turn health services research into health policy change. The development not of centers of excellence, but of centers of experience, centers of team experience. And in case you thought it was the surgeon, it was not surgeon volume that drove this improvement. It was the team. This is the skill of the head and neck nurse to detect an early failing flap at 2 in the morning. This is the SLP who detected early aspiration and avoided an aspiration pneumonia and potentially death. This is about the radiation, medical, and surgical oncologists working together to minimize toxicity and maximize survival. The team working together. This is not all, however, of moving the patient to quality or centers of experience. There are areas of head and neck cancer practice where the volume of surgery can be attained in a disseminated service model, just because that service, that disease, is more common. But critical to this is measuring outcomes and maintaining quality. We have 8 head and neck cancer centers in my province of almost 14 million people, and the 150 or so hospitals in our province, in the 14 regions of our province, about 40 perform thyroid surgery. Here, it is critical to ensure that patients' care in Center A in Thunder Bay is the same as Timmins, as Toronto, as Hamilton. It is critical to measure multidisciplinary integrated care and also quality and outcomes. And here's a graph showing the extent of surgery in the 14 regions of my province of Ontario. We could do this by hospital, we could do this by surgeon, but if we understand that there's no variation in patients, why is there variation in care? Why is the treatment of one patient with the same disease in one region so different from another? So measuring quality performance across the system is absolutely critical. Here's the lymph node retrieval rate for patients undergoing central compartment neck dissection in our province, where 6 or greater lymph nodes is viewed as acceptable. You can see that while the rate of patients having 5 or less lymph nodes retrieved is decreasing modestly, we still have work to do. But you see, we cannot improve something if we are not measuring it. Measuring it in a system, measuring it in a region, measuring it in a hospital, measuring ourselves. So I think we've reached a waypoint, in an era, where 100 years ago, a great Canadian physician who was a leader in bedside teaching and teaching medical students about observing and recording and tabulating and communicating about a patient. Perhaps 100 years later, as we reach the waypoint of system management, we can say the same about how we are measuring ourselves in the system. Observe, record, tabulate, and communicate. But as we measure ourselves, let's remember that we have to do it in a non-punitive way. We have to use data in a positive and not in a negative way. As we share data, the feedback is usually, well, that's not my data. First of all, the data is usually wrong. I want you to audit. So we audit, and the data is actually pretty good. And then the feedback is, but that's not my data, that's his or her data. So increasingly, people want their own improvement or own measures about how they're performing in their system. And we give it to them, and we rely on the most competitive animal in the medical kingdom, the surgeon, knowing his or her performance in the system to improve, and doing it in a non-punitive way. I think there are 2 things that will solidify our society's position as providers of excellent care in head and neck surgery. First, what we know and how we teach the next generation of head and neck surgeons, for that is our legacy. Number 2, how we perform, and not to be afraid to show it and to always improve. Which brings us to our society, at its waypoint, at its reflection point in its history, AHNS 2.0. And as our society reaches the waypoint of reorganization, we have the opportunity of engaging more of our membership into leadership positions to integrate and to perform better, to have divisions that reflect our mission in research because we have visionaries who create and innovate, our mission of educators because we have educators developing curricula and standards of care for the next gen of head and neck surgeons, and to measure our performance as fellowship providers in our programs, to ensure that we are delivering the best quality education programs. Our mission of patient care to develop guidelines and standards and to ensure that we measure our performance and how our patients are being cared for. In all of our subspecialties of practice, in all of our sections, because we are one, we are a sum greater than its parts. One of the fantastic benefits of being an academic surgeon is meeting people at different centers and at different meetings. It's where acquaintances become colleagues and colleagues become friends. And I was in Taiwan about 3 years ago with Amy Chen and her family, and she recommended this book, Boys in the Boat. The story of the 1936 rowing eights from the University of Washington, American schoolboys who literally took on the world and won. A great book that emphasizes teamwork, the concept that together you are stronger. Those university young men understood during the course of their journey the power of one, the power of a smoothly working machine, a poem of motion, a symphony of swinging blades. Well, Amy probably didn't understand that, and Ehab obviously stole these slides from me. But this book had special significance to me. You see, I was a boy in a boat once, and while I had success as a single paddler, as a doubles paddler, the best, quite frankly, was when we won as a team of excellence, a team of experience, highly integrated, high performance. The simple notion of everyone pitching in and pulling together. And we had great parts in this boat, by the way. There were 3 Olympic medals in this boat. A silver from LA, a silver from Montreal, a gold from LA, but we left those egos at the door. We all knew that no race was perfect. Everyone made a mistake in every race. But there was no blame, because when we were one, and we all knew that if one of us failed, all of us failed. So let's remember as we work on our teams, whether we are establishing the new high-performance research team of researchers and physicists, and nanoparticle engineers and surgeons and computer scientists, whether it's a team of health policy implementation across a healthcare system, whether it's a highly integrated, high-performance clinical team providing radiation medicine, surgery, and of course, survivorship, or whether it's a division team, a member of a university surgical division delivers an educational mission in our educational or in our fellowship programs and positions the ambassadors of our specialty in the next generation as leaders of our specialty. Or whether it's the members as the best damn surgical team on the planet, let's remember we are a sum that's greater than its parts. So as our society reaches the waypoint of reorganization as we launch AHNS 2.0, we are well positioned to deliver on research, on education, quality care for our patients. And while we may have services instead of committees, the highest form of service, quite frankly, to our society, and sections that represent our subspecialty interests, and divisions that represent our mission, we cannot be sectioned and we cannot be divided. For there is no organization that I have been part of where the sum is truly greater than its parts. It has been one of the greatest professional honors to be president of this society. And most importantly, I want to thank you for some time to reflect. Thank you very much. Thanks so much. Now, I would like to introduce Dr. Ehab Hanna, which is the next So there must be a slide deck up there. I think it just keeps going here. Can you keep going on this one? It should just keep toggling through. Now, here we go. So, it gives me a it's a great honor to introduce our new president. As I said during the business meeting, if you haven't seen this picture or know Dr. Hanna, then you're not a head and neck surgeon on the planet. After earning his medical degree, Dr. Hanna completed a surgical internship at Vanderbilt University, a residency in otolaryngology head and neck surgery at the Cleveland Clinic in Cleveland, Ohio. Ehab then went on to fellowship training in skull base and head and neck surgery at the University of Pittsburgh. And then he joined the Department of Otolaryngology, University of Arkansas, where he quickly rose to the rank of full professor, and he joined the MD Anderson in 2004, where he is currently the professor and vice chair of the Department of Head and Neck Surgery. He's obviously an internationally recognized head and neck surgeon, an expert in the treatment of patients with skull-based tumors, as well as head and neck cancer, and he's medical director of the Multidisciplinary Head and Neck Cancer Center and co-director of the skull-based tumor program there. He's authored over 350 publications, invited chapters, many books, and so on and so forth, and of course, is well known that he's editor-in-chief of the journal Head and Neck. He served as the president of the North American Skull-Based Society in 2014. He's an accomplished wind surfer, practices weekly, twice a week, I think, and races weekly as well, and was in the national championships some years ago, not that long ago. When he's not on the water, he's under the water. He loves to adventure and trek in various areas and parts of the earth. And most of all, of course, he's a great physician, an accomplished physician, well-liked physician, and a dedicated doctor. His real passion, like all of us, is his family, his wife Sylvie, his daughters Gigi and Camille. And quite frankly, Ehab is just a great guy. And I have no doubt that Ehab will provide strong stewardship during the course of the society's life as we implement AHNS 2.0. At least we've got all the bylaws and all the structure done, and now it's yours to build. So Ehab, congratulations. I now pass the, hey, we're not bad, 11:04. So we're not too far behind. That's pretty good. So we start the Shaw Symposium next. If I can invite David Isley up to the podium.